Welcome to this European Society of Thoracic Surgeons, Women in General Thoracic Surgery, and Women in Thoracic Surgery webinar series brought to you by CTSNet. Women in Cardiothoracic Surgery, United Globally for Progress. Today's discussion will be centered around fighting inequities in cardiothoracic surgery. We're glad you could join us. Please note this webinar is being recorded and will be available this Friday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the co-moderators for this webinar, Dr. Stephanie Worrell and Dr. Maria Teresa Tsukazin. Dr. Worrell is a thoracic surgeon at the University of Arizona. Dr. Tsukazin is the Chief of Thoracic Surgery at Hospital São Lucas. Thank you for joining us, Dr. Worrell and Dr. Tsukazin. I'll turn the panel over to you.
Thank you very much, and thank you for the audience for taking this time today to explore this topic. I'm very pleased to introduce this group of esteemed cardiothoracic surgeons to our audience. We have Dr. Cherie Erkmen, Professor of Thoracic Medicine and Surgery at Temple University of Medicine, Dr. Shanda Blackmon, Executive Director of the Lung Institute at Baylor College of Medicine, and Dr. Douglas Wood, Professor of Thoracic Surgery at the University of Washington.
We would like to quickly remind the audience that they can type the questions for the panelists and at any time using the Zoom QA function. Questions will be addressed following the conclusion of the third presentation. There'll be one presentation by each of our panelists, and following the third panelist, we will open for general discussion and input from the Q&A. So without further ado, we would like to open the floor with Dr. Erkmen's presentation, Fighting Inequalities in CT Surgery Salaries.
Great. Thank you so much for the opportunity to speak and the opportunity to talk about this issue. It's important to all of us, and looking at a beginning point, I think it's great to start with Nina Starr-Braunwald, some historical context. At the age of 32 in 1960, she designed, developed, and implanted the first prosthetic heart valve. And contemporary with her, my own mother was a lead scientist at NOAA, and women of this era were earning about 60 cents on the dollar. So for every dollar that a man earned for the same job, women earned about 61 cents. So where do we stand now in 2020, in this decade? To understand this and to understand this in the context of cardiothoracic surgery, we looked at this data. Christine Chin and Shilpa Agarwal are medical students and residents at Temple. And looking at this, focus on the blue line, that's cardiothoracic surgery. In 2010, in academic practice, there were only 4.6% of our workforce was women, and it goes to about 11.5% 2021. This is worse than in surgical specialties and in clinical medicine as a whole. When we look at the salaries, this is very disturbing. We see that at the assistant professor level, women in cardiothoracic surgery earn 84 cents for every dollar that a man in cardiothoracic surgery earns. And so as you look at different academic ranks, it's just about 77, 78, 79. And to make this point really hit home, you look at a man and a woman in cardiothoracic surgery, and they work all of 2023. A man gets a paycheck. But for a woman to earn as much as a man, she would have to work all of January, all of February, and all the way up into March 18th to equal what her male colleague earned. And our male colleague is not just sitting around. He's well on his way to earning into 2024, and a woman is just beginning in March. So you can see how this pay inequity continues to compound. And in cardiothoracic surgery, we see that female professors earn less than their male associate professor colleagues. So we're not different from the rest of the country. All jobs, we're looking at about 83 cents on the dollar of what women earn compared to men for the same job. So we have gender data. What about as it relates to race and ethnicity? And this is Nosa Enofe. He's one of our fellows at Temple, and Anastasia. She is um, a student at Villanova. And they looked at the race and ethnicity breakdown from trainees all the way to chair. And you see that among ACGME trainees, we still have a majority of people who are white, and the diversity decreases with increasing academic rank. And then looking at the salary. Now, this is hard, so we'll spend a little bit of time, but let's just focus on the assistant professors. The green bar represents white cardiothoracic surgeons. At the assistant professor level, Asian, Black, Hispanic, Latino are all earning less. This is a phenomenon that we see also in surgical specialties and in all clinical specialties, that there is a consistent advantage of salary in terms of white and non-white. But as you look at associate professor, professor, chief, the data starts to get a little bit more varied. Something that's consistent in cardiothoracic surgery and not other specialties is that Black and African American cardiothoracic surgeons consistently earn less than their colleagues. Interestingly, looking at Hispanic and Latino, the data is very mixed. We just don't have enough people to look at chief and chair. And among Asians, we do see that there is some increase in salary compared to their white colleagues. And one of my colleagues, Leah Backus, she always says, this is great data, but you need to look at the intersection. What is the intersection? It's very difficult because we just don't have enough people who are at the professor chair and chief level, who are women, who are African American, Black, Asian. So what we do have is a little bit of intersectional data. When we look at the first 4 bars, these are assistant professors. White is green and Asian is orange, and the hash mark are women. So consistently, women are earning less than men. Women who are Asian earn 80% that of their male white colleagues. Asians who are male earn 92%, so there's a little bit more parity. And women, of course, earn less than men who are white. So looking at the associate professor level, the next 4 bars, you see that Asian men earn more, but it's not an advantage that Asian women enjoy. They're still earning less than their colleagues. So it's important to see these intersections really play a role, because consistently women earn less than men. In all specialties, women earn less than men, and in all academic ranks, women earn less than men. So these studies have limitations. They're limited to academic practices, and there's no reporting of subspecialties. And of course, there are many, many mechanisms of compensation and therefore mechanisms of disparity. But a step forward was in the last year, Dr. McGilvery set forth a presidential task force. Dr. Blackmon was on this task force as well, and to understand compensation with accurate data. And the first survey went out in October of 2023, and we had a good response. And it really confirmed everything that we heard in previous studies, that there is a gender disparity in compensation, 78 cents on the dollar in cardiac, 81 cents on the dollar for thoracic, 75 cents on the dollar for congenital. So regardless of subspecialty, there is a gender compensation disparity. When we look at base compensation versus total compensation, there's a gender disparity. Academic versus community settings, there's a gender disparity. In small and large service populations, there's a disparity. So it's an ongoing theme. It's like the Dr. Seuss book, Green Eggs and Ham. whether it's a hospital or a community, a bus, a train, there's gender disparity. And interestingly, we see this again, women of my generation, 11 to 20 years out of practice, earn less than men with fewer years of experience. So disparity can be based on any number of factors. We have the most data about gender, but any of these other factors, where you trained, geographic location, accent, perceived socioeconomic status, can all be a reason for bias and perhaps disparity. This is a very important point. A great study by Blair Marshall, gender differences in Medicare payments. So if there's gender disparity, there's a disparity in collections. Women collected $25,000 less than their male colleagues. And when it's factored for surgeon, for patient, for procedure, there's still a gender disparity in what women collect from Medicare. So this affects everybody. A department, an institution, it's just intolerable to have this inequity. And without transparency, everybody feels unfairly compensated. So the good thing about this is that there is no enemy. There's no one person to blame or group of people. Everybody has a benefit. Disparity impacts everyone, but also equity benefits everybody. And we should strive towards unbiased systems, fair working environment, fair evaluation, and compensation based on transparent metrics. Huge important. We need the data. We need this type of data to drive our direction in the future. So circling back to Nina Braunwald and my mom in the 60s earning 60 cents on the dollar compared to the male colleagues, we here in this decade are earning about 80 cents on the dollar. And hopefully, this is my daughter with my mother, by the time she enters the workforce that we will get parity. So thank you very much. And I understand we'll wait for questions to the end.
Dr. Erkmen, without further ado, we will open the floor for Dr. Blackmon's presentation, Fighting Inequities, Social Benefits in CT Surgery.
Can you see my screen?
Yes.
Okay. Okay, I will be talking about fighting inequities in family and social benefits in cardiothoracic surgery. I'd like to thank the group from Women in Thoracic Surgery, Women in General Thoracic Surgery from ESTS, and CTSNet for the honor of speaking to you today. I don't have any relevant disclosures, except for I do speak about some of these issues in a recent book that I published entitled The Support Group. So I'll go through the problem, some terminology, and hopefully some solutions. So I think it's easy to say that women do not have it all today in cardiothoracic surgery, not just for the reasons that Dr. Erkmen has elucidated, but also for many other reasons that I'll be going through. Some important terminology that I think will help if you understand. Discrimination is the unjust or prejudicial treatment of different categories of people, especially on the grounds of ethnicity, age, sex, or disability. Gender inequity is the lack of fairness and justice for women. Cronyism is the promotion of a younger or inexperienced individual over a more qualified candidate for the purposes of exerting control. Tokenism is promoting an inexperienced or underqualified individual, particularly from an underrepresented minority, solely just to meet a quota or fill a position. And microaggression is a statement, action, or incident regarded as an incidence of indirect, subtle, or unintentional discrimination against another. So female surgeons and trainees in a particular study cited below were more likely to be responsible for household activities such as childcare planning, grocery shopping, and meal planning. And this created some imbalance both at home and at work. In this particular survey of a surgical workforce, women were more likely than men to be married to a professional, which affected their daytime responsibilities, and they were more likely to be married to someone working full-time. Women were less likely to be on a tenure track, and women faculty were more likely to be primarily responsible for childcare planning, meal planning, grocery shopping, and vacation planning. And gender-neutral responsibilities included financial planning and monthly bill payment, which women and men seem to share equally. So how does gender and additional society identify factors that shape our experiences and our perception of teamwork in the OR? A particular thematic analysis identified some of the following issues: harassment and bullying, having to accept how it is, proving yourself, women taken less seriously or not listened to, differential respect, lower confidence in the decisions made by women, and the boys' club mentality, women being outnumbered in the minority. This thematic analysis identified several issues specific to nursing relationships, such as impression management, cases not being prioritized, assertive women surgeons being perceived negatively, tension with other female nurses, and not being perceived as physicians and instead being called with other titles, and coworker versus friend, women feeling like they have to befriend all of the other coworkers in a way that men do not. So in conclusion, at the end of this particular publication, I thought this was very profound. They stated that our findings suggest that the highly gendered reality of the operating room created an environment conducive to breakdowns in communication and patient safety risks, in addition to diminishing team morale, psychological safety, and provider well-being. Consequently, until teamwork interventions adequately account for gender, they are unlikely to be optimally effective or sustainable. Another study that looked at a thematic analysis of multiple different focus groups to try to get at the heart of what was happening discovered that harassment and difficulties in establishing legitimacy led to unfavorable work environments that led to gender barriers in surgery. Insufficient support, work-life balance, and negative perceptions of working mothers led to challenges in motherhood, which also led to barriers. Exclusion, conforming to male standards, and inequality in career progression led to male-dominated culture, and higher expectations and stereotypes led to societal pressure. Dr. Esther Chu, in an episode of AMA Moving Medicine podcast, emphasized that gender bias affects not only women, but also other identities, such as those race, ethnicity, sexual orientation, and those patients with a disability. In the National Academy of Sciences, Engineering, and Medicine, they reported a highlighted sex harassment in academic scientific fields. It included gender harassment, which encompassed verbal and nonverbal behaviors conveying hostility, objectification of women, exclusion, or the second-class status of women. So we looked at several studies that demonstrate implicit bias and saw how it negatively affected women in academic medical careers and may limit opportunities or hinder professional advancement. The slower advancement of women may be related to gender bias or promotion. Gender bias also affects how we refer to physicians and other professionals, and both men and women scientists are more likely to call men, but not women, by their surname, which we've seen and tried to address in local society meetings. The analysis of physician-patient communication also showed that women doctors in general have different communication styles than their male colleagues. Women are reported to be more caring and empathetic and ask more psychosocial questions, speak more emotionally with their patients, and spend more time. However, this expectation and communication style may eventually lead to some burnout with women as they are disproportionately referred to a group of patients that may be more complex or have unreasonable expectations. Women physicians frequently adopt an empathetic style of interaction and that's called mother transference, as well as an innate biological characteristic, which may affect the way that women are perceived. If healthcare models don't provide extra time to interact with these more complex patients for women who are taking them on at an increased burden, again, it can lead to longer work hours or burnout. And then another study in 2018, when discussing female surgeons, the motherly approach to patient care is likely the best for the patient, but perhaps could be personally draining to female surgeons. So we do need a lot more assessment in this area. We also need to do better at assessing workplace and environment, workplace violence, as well as home violence. This picture on the bottom right is of a colleague of mine who was harassed both at work and at home and was ultimately murdered by her husband at home. Career advancement, representing underrepresentation in leadership positions, slower academic promotion, fewer professional awards, fewer grand rounds or national lectures, and attrition. Some of the financial considerations were broadly discussed by Dr. Erkmen, which included less research funding, as well as less compensation, as well as psychological challenges like harassment, imposter syndrome, not feeling a sense of belonging, or burnout. So implicit or unconscious gender bias can be assessed by the implicit association test. And this test was applied to a group of patients, applied to a group of 43,000 healthcare professionals. And they found that both groups associated men with career and women with family, although the implicit bias score was slightly higher in healthcare professionals. The implicit bias scores of women and healthcare professionals were higher than their male counterparts, and healthcare professionals of both sexes had explicit biases. Using a gender specialty implicit bias association test by the authors, they found that women were more likely to be associated to family medicine and men more likely to be associated with surgery. Some of these trends have affected how we perceive equity to access leadership training, access to mentorship and sponsorship, educational initiatives, diversity, and equity in pay. So how do we begin to address these issues? Some strategies include implicit bias training, development of a transparent and equitable compensation plan, transparent processes for promotion and hiring, mentorship, and sponsorship. Achievement of equity for women physicians requires effort and ultimately a cultural change, including gender equity in the medical profession leading to improved wellness, retention of female physicians, improved access to healthcare, overall improving the quality of care. And I won't go through all of these strategies, but I am showing them on the screen so that you can go back and go through them because I think they're so important. There's just not enough time to cover all of these. So some of these studies of interventions to achieve equity suggest benefits to women faculty at academic institutions. And this particular study demonstrated even a 5 times increase in promotion of women going to associate professor. The American Board of Surgery, as well as the American Board of Thoracic Surgery, has changed their family leave policies. And this was very well covered in a recent session in the Society of Thoracic Surgeons meeting that was an idea that formed from Dr. Jennifer Romano, who actually helped to write some of those new policies for the American Board of Thoracic Surgery, promoting equal opportunity for both men and women to have equal leave and engagement in their families. Essential to this success is commitment by leadership. Interventions including communications from the leadership, problem assessment, leadership development, salary adjustment, education about gender bias and discrimination, effective mentoring, as well as CV reviewing, as well as looking at other studies that help us enhance the promotion of women. Some other solutions include fostering a supportive community, encouraging personal and professional development, policy change, and diversifying the healthcare workforce to match the population that's served. Some of the activities that even Dr. Wood has been heavily engaged in include the He for She movement, as well as the She for She movement and other activism activities like I Look Like a Surgeon or #LookLikeASurgeon or the New Yorker Cover Challenge. We've also seen that sponsorship is key. Program planning, panels, postgraduate sessions, expert panels, course directors, speakers, and discussants are all appointed by their sponsors. I've also given a talk at multiple institutions on ways to attract more women into the surgery. Increasing the pipeline is no doubt a definite good way to enhance our opportunities for advancement. Infographics also help us to communicate what's going on. This particular infographic was promoted by Women in Thoracic Surgery, showing our underrepresented distribution in rank promotion for different levels, as well as in our society level. This particular allyship paper that was published by Tom Varghese, Mara Antonoff, and several other colleagues showed that increasing access to mentors and sponsors helped to represent an important area to support women in cardiothoracic surgery. You can see that over time, we've made a lot of progress, starting for just a few women in a room having coffee to now more women than we can fit inside a ballroom. So in summary, gender inequity in medicine is a multifaceted issue that requires ongoing effort to promote quality, diversity, and belonging, as well as inclusivity. And solutions involved addressing bias, fostering a supportive environment, and ensuring fair opportunities for all. I'd like to thank you for your attention.
Thank you very much, Dr. Blackmon. That was a very terrific and comprehensive overview. So to the audience, please continue to enter questions into the Q&A and we'll address them at the end of the panel. We'll now move to our last speaker, Dr. Wood, and he'll talk to us about professional allyship in CT surgery.
And let me just double check and make sure you're seeing my slide okay.
Yes.
Terrific. Well, it's a hard act to follow, following Drs. Erkmen and Blackmon, but I'm really appreciative of being included in this webinar series. We're all trying to accelerate gender equality in cardiothoracic surgery, and it's a privilege for me to add a male voice to this because it's especially important for men to be better allies to women colleagues. And that's the perspective I'm going to give in this is a perspective of a man and what men should do, and especially that is dominated by men in terms of being an ally for women to mitigate the continued disparities that have been well highlighted and to promote opportunities for women in cardiothoracic surgery. And I'm going to start with a quote from John Stuart Mill. A person may cause evil to others, not only by their actions, but by their inaction. So the point of this certainly is that we can't stand on the sidelines as innocent bystanders to mistreatment, microaggressions, harassment, or injustice. Being an ally means being willing to act, being engaged, and being responsible for positive change. And I also want to start by giving credit to incredible female allies who have helped teach me about the challenges they've had in their careers and who inspire me with their strength, resilience, and leadership. I acknowledge that I am still learning. I've not lived the experience of my female colleagues in surgery, but I have learned valuable lessons from them on how I can be a better mentor, ally, sponsor for medical students, residents, junior colleagues, and peers. I'm going to tell a little story about an experience I had at a small faculty dinner a few years ago. Partway through the dinner, I told a story that I've told many times before. Those of you that know me know that I can do that at dinner. This is a story that I thought was really funny because it was an embarrassing story about a father with his 14-year-old daughter enduring sexual themed jokes at a Times Square comedy club. And I had told this story many times, and I kind of considered it edgy and even self-deprecating, but never considered that others might find it offensive. The next day, one of my highly respected female colleagues took me aside and gently described how they were embarrassed and uncomfortable with my story, and that they felt others were also. I paused and I thought about that feedback that I was receiving from somebody, a colleague and a friend that I respected, and she provoked an epiphany in how my words and actions are perceived by others. I apologized to my colleague. I thanked her for having the courage to speak up, and I also thanked her for having the respect for me to take the initiative to give me that feedback. I've never told that story again. But I still make mistakes. But her feedback has helped me be more cognizant and more sensitive, and hopefully a better colleague for the people that I work with. And I just want to point out, this is only one of innumerable anecdotes that I have of strong and influential women who have helped me be a better leader and ally. When I think about ways that we can best be allies for each other and how men can be effective allies for women in surgery, it's helpful to think about the different aspects of how we show up as allies. One is at the individual level, where we educate ourselves and model the type of behavior and mindset that we desire in our professional environment. But I think what we most commonly think of when discussing allyship is the interpersonal support, those actions or interventions that we do for others and that they do for us, like I just outlined. And they help advance opportunities or mitigate microaggressions. But there's a third type of allyship as well, that individuals in powerful and influential positions can influence structural changes, some of the things that we just heard about from Drs. Erkmen and Blackmon, and support diverse individuals within our professional environments. So let's take those one at a time. What can we do as individuals? Well, first, we can find female allies who are good confidants and advisors. We can also be intentional about avoiding remarks or actions that create a hostile work environment for women. For example, this includes not participating in a bro culture or locker room banter and actively discouraging it in others. We can all be made more aware of and engaged with gender issues in surgery by getting involved in women's organizations, groups like Women in Thoracic Surgery and ESCS Women in General Thoracic Surgery. And in our home institutions, there are likely seminars or programs related to women in science or medicine that are also valuable for male surgeons, especially those in senior roles. For those involved in social media, following some of these women's groups or prominent female surgical leaders provides yet another way to learn about gender-related issues, barriers, and problems in surgery. My point here is to be curious. Show up for meetings about gender issues. Show that you're interested. Show that you can listen. Demonstrating curiosity and willingness to learn and engagement can be a very effective way of modeling allyship to others. For most of us, it is the interpersonal allyship that we understand best and try to practice effectively. Fundamentally, it entails support of our colleagues, particularly those who have less power or representation. Sometimes this may closely resemble mentorship when we provide advice or counsel, or resemble sponsorship when we promote colleagues for consideration of professional opportunities. But allyship also includes being a strong bystander, providing solidarity and support for our colleagues when they are subject to microaggressions, intimidation, or exclusion. The first thing I'll emphasize is we should be a friend and confidant to our colleagues. That's one of the most substantial ways that we can be an ally. But we have to discuss sexual harassment, which is a persistent specter and an additional workplace burden that female colleagues carry daily, an extra weight of navigating an already complex professional environment that requires women to think about their dress, their words, potential secondary agendas in their professional interactions. And this is a burden that most men do not face, and therefore is easily overlooked and underappreciated by even well-meaning male colleagues. We can be important supporters and allies for colleagues when we observe unwanted sexual advances or incidences of gender bias or other hostile behaviors. And it's really critical that men in particular be alert and observant for harassment that they witness directed towards their female colleagues. Depending on the situation, in some situations, it might just be helpful to check in with our colleague after an incident. Sometimes we might need to speak up in the moment to demonstrate recognition of and intolerance for gender harassment. And then in some more serious cases, male allies should be proactive in helping to report hostile behavior to a chief, chair, or human resources. This aspect of sexual harassment has another consequence, and in an effort to appear above reproach and with the intent of preventing any allegations of harassment, some male surgeons have chosen to avoid one-on-one meetings or social interactions with women students or surgeons. And while this might start off as well-intended, this approach generates a whole different form of gender discrimination. Avoidance of private meetings and confidential conversations with female students or colleagues denies them important networking and relationship building opportunities, as well as the benefit of a senior surgeon for advice and mentorship. This type of self-defensive principle with women undermines important trust that is critical for establishing strong personal and professional relationships that foster opportunities for support, mentorship, and sponsorship. So the professional environment in surgery is also fraught with a wide variety of gender-based microaggressions. They can be verbal and nonverbal. Sometimes they're obvious. Often they're very subtle and insidious and communicate negative, hostile, or derogatory messages that marginalize our female colleagues. Those that involve sexual objectification, sexist humor, sexist language, but more subtle and no less damaging, are implications of gender inferiority represented by mansplaining. You might even say that's what I'm doing now. And men co-opting ideas from female colleagues, or men speaking over women during group meetings and undermining assertive women by labeling them with sexist stereotypes, bitchy, bossy, aggressive. I'm going to suggest that you observe the next faculty or committee meeting that you're attending and pay attention to who's speaking. With a little observation, one can note that men generally do most of the talking and may even step in and interrupt or speak over a woman when she is talking. A good ally could call on a woman to express her opinion or redirect a discussion back to a woman who has just been interrupted by a male colleague. And as noted by Dr. Blackmon, it's really unclear why women surgeons are so commonly referred to by their first names in professional meetings and introductions. This is a clear example of implied gender-based inferiority that is subtle yet insidious in undermining women's surgeon status in their career and their institutions. Once recognized, this is really simple to address, and I encourage all of us to pay attention to this issue and purposely assure that we are introducing and addressing female colleagues with their professional title. If anything, I think it's worth overcorrecting given how pervasive this habit has become in our professional environments. Finally, and this bridges into sponsorship, I say also look for opportunities for female colleagues to be showcased in a meeting, on a panel, on a committee, or in a leadership position within a hospital or your specialty society. As men, we should avoid organizing or accepting participation in a manel. There are many qualified women who will add diversity and strength to the panels that we discuss. Now I'm going to move to the organizational level, because at the organizational level, one of the things that we can do is develop a women's group or women's council, both to support the networking of women surgeons with each other, but also provide a forum for evaluating the environment and identify problems or barriers for women surgeons that can provide important advice to senior leadership and recommending policies to improve the workplace for both men and women. Structural allyship is important in recruitment and promotion. However, an important factor is successfully recruiting and promoting women is assuring that the department confirms equity and fairness, the issues that Dr. Erkmen was talking about. The environment has to also be welcoming and supportive of women surgeons, like Dr. Blackmon was discussing. It is critical to assure gender parity in compensation, academic promotion, and leadership opportunities. This requires a willingness to look specifically at data around compensation and promotion, identify disparities where they exist, and actively fix them. Secondly, work schedules, department activities, environmental culture should be recognized and be supportive of a work-life balance that supports all individuals in their professional, personal, and family activities. It is much more often that women are discriminated against because of an outdated viewpoint of work ethic that overshadows the individual and the family. Both men and women benefit from family-friendly policies and actions that include consideration of appropriate meeting times, options for remote meeting attendance, family leave policy, and flexibility in work and call schedules. And this includes gender-specific accommodations around pregnancy and lactation, along with gender-neutral accommodations around parental leave. I think it's also important to comment on this because it's difficult for senior leaders to navigate the delicate balance between female inclusion in various committees and groups and tokenism and pressure for women to participate in roles that they may not want. Well-intended efforts to develop a women's council or diversity council may disproportionately direct women into these roles, particularly in cardiothoracic surgery, where there may be very few women to take on these responsibilities. It's important to recognize that female colleagues have their own portfolio of interest and expertise that they wish to prioritize, and that these may not be enhanced by filling gender role needs of the department or institution. Further, it's common that many of these roles are volunteer and do not come with specific support in the form of allocated time or additional compensation. So, therefore, if it's not in the sincere interest of the faculty member, these responsibilities actually become a form of a gender tax that places an additional and unwanted burden on a woman surgeon who wishes to direct her priorities elsewhere. 3 years ago, Drs. Pompili and Bacchus coordinated an outstanding special issue of the Journal of Thoracic Disease focused on women in thoracic surgery, and they developed an incredible group of international authors. I encourage any of you who want more information to go to this whole issue, and I put my reference here for any of you that want to further explore this aspect of allyship, and particularly allyship of men for women in surgery. And just as I wrap up, I'll summarize that we recognize that women suffer unequal opportunities, clinical, academic, and leadership roles, and this is further represented by disparities in compensation, time to academic promotion. And because of the prevalence of men in surgery and in cardiothoracic surgery and in leadership positions, men have an outsized role in supporting a culture that empowers an equal opportunity for career success and advancement for both men and women. First and foremost, men can be critical allies to their female colleagues by supporting and promoting the women that they work beside every day. Men are also important mentors for women, providing a safe space for frank conversations and career advice. But men are also important sponsors for women colleagues as well, talking about them, promoting them, helping launch them into committee or leadership positions, and opening doors for clinical or academic advancement. Men should not stand on the sidelines and should be engaged and proactive as they work with women for gender equality in surgery. Thank you very much.
Thank you, Dr. Douglas Wood. You're excellent female surgeons for sure. Thank you for listening to us and give the feedbacks. So now we're going to start our Q&A questions. I have my first question, actually it's for Dr. Erkmen and Dr. Blackmon. So I wonder how maternity has an impact in intersection for the compensation. So basically here in Brazil, we had a survey with all female thoracic surgeons, and basically 50% said their income has decreased after maternity, not just for the maternity leave, but like forever. So also the working hours, none of them came back what it used to be before having the baby. I wonder how that also interferes in the intersection.
I can comment from the compensation perspective. We do know that women start out regardless of their motherhood, parental status at lower salaries. And we also understand when we look at the other side of the career spectrum that many men are having things like cervical injuries and surgery, lost time because of occupation-related injuries and illnesses, but we're not docking their pay for expected or assumed injuries and time away from work. Yet we do that for women regardless of whether they have children or not, or regardless of whether it impacts their work or not. So I think you're right. There is this double standard of well, women are having children and getting pregnant, and therefore that's the explanation for why there's a salary disparity. But it doesn't make sense for why that disparity, like you said, extends beyond childbearing and childrearing years all the way through a career, and it doesn't apply equally to men who also have family issues as well as personal health issues.
I can just dovetail off of what Dr. Erkmen said, which is essentially, even in institutions where I've been working, having children, my husband's been a stay-at-home dad for my entire career. So even though I've had twins, there has been pay disparity within some of these institutions due to gender alone, as far as we can tell when matching RVU. So if a woman has a stay-at-home father taking care of the children and is not taking additional time off and is doing the same RVU, in our study, we found that there was still pay disparity when you're matching RVU, when you're matching workload, hours worked, it still seems to exist.
Thank you. We have a couple questions from the audience as well. This probably goes to all of you. Where would you suggest someone starts to raise awareness of gender equity at their department institutional level locally? We have a lot of colleagues coming from different countries, and we want them to create some change in their local environment. Any suggestions?
So I would think that some change that you want to see needs to start at a grassroots level as well as at the top. So relationships are very important. Like Dr. Wood said, I think it's very important to find allies in your leadership who will promote and advocate for you, as well as people that have similar impressions and circumstances that you do to help raise awareness from the bottom up. I think if you form women's interest groups, but you don't empower them, you'll end up with a lot of meetings where people are complaining, but nothing's getting done. And I see that a lot. You have to empower these women's groups to make change. And a perfect example is in a prior institution where I was, the men had a locker room for attending men and a separate locker room for men residents, male residents. And the women locker room was combined faculty and residents. So these locker room conversations that are happening with the male surgeon colleagues, they had a different environment than the female counterparts. The other thing that was discovered when the women snuck into the men's locker room, they were being provided toiletries. The women were not. There was disparity throughout the whole thing. For 10 years, the women complained. There was a women's group and nothing happened. So this is a clear, obvious example of something that's little, but every day a woman goes to work and goes into a locker room and is reminded that she's different. And it's very subtle. Yet, if you're not empowered to make the change and you're not heard, it doesn't make a difference. It just increases stress and serves as a reminder.
Very good answer. Another
Yeah,
question.
I'll just add that, Dr. Blackmon said it, but I want to emphasize that I think because men are more often in the powerful positions in our environments, in a place where this is still a new concept, I think it's key to find a champion, an ally, that is willing to work together to change the environment. I think it's very hard, just as Dr. Blackmon is talking about, for just having a women's group or some women that are trying to push for equal access to a variety of opportunities, often aren't in a powerful position to make it happen. And that is a place where I think a big point of what I was discussing is male allies are really critical, and a champion that decides to also lean in and work together with their women colleagues can help make a difference.
And I'd like to add that I think the scholarly work in this area, Dr. Blackmon and Dr. Sepa did a study of harassment, hard data, very clear results that there is sexual harassment against men and women, not just women, but disproportionately women. Dr. Mara Antonov did a great study looking at the way women are perceived in letters of recommendation. So we're scientists, we're surgeons, we look at data. And so all of the scholarly work that's being done in this area can be printed out and handed over to leadership to say, this is a nationwide issue. We're not laying blame on you, but we can make progress here. This is mirrored in our institution, and let's move forward in an evidence-based method.
I would just like to comment additionally that it is unfortunate that some of the burden of proof is laying on the shoulders of many of the women. Doing these types of studies and proving that there's a problem when we already know that there's a problem takes a lot of work and doesn't necessarily help you get promoted to professor, and sometimes makes you perceived to be annoying because you're complaining that your colleagues don't have a place to pump at meetings, or they don't have a place to go when they're trying to prepare for something. So I think that this is a good example of what Dr. Wood said, where sometimes that burden of proof for the people trying to advocate and empower is laid upon their shoulders. And that's why we need male allies. We need the empowered people to empower those who are not empowered.
Thank you. We have a great question. How would you advise a graduating trainee to navigate for the first contract, first salary?
I would say go to a place that will advocate for you. If you're going to an institution that you're already having to advocate for pay equity, you might be going to the wrong institution. So make sure you're going to the right institution. And if you are, you don't have to advocate, but be aware of what your colleagues are getting paid. Frequently, men who support women will help collaborate with you on that. And if you don't think that that's happening, you could reach out to the ombudsman, and many institutions now have a pay equity evaluation, and you can ask for that. And they will look at your pro forma and compare your pro forma against the pro forma of other male colleagues coming in a similar position and advise you accordingly. And that's a really great option because you may not be aware of some of the data or have access to the data, and they do.
And we're coming out with a hopefully a guide soon that outlines the different types of compensation. So at least you, as a trainee coming to the negotiation table, have the vocabulary. These are the types of ways people can be compensated, and things like flexibility of schedule may not cost a lot of money to a chair or a chief, but is very valuable to you as an individual. And so being able to look at all the ways that you can be compensated and having that on a piece of paper to prep you before your negotiation, I think that will be really helpful. And again, the workforce of diversity, equity, and inclusion, cardiothoracic surgery practice models, and early career are collaborating to develop this guideline, at least for vocabulary of compensation.
Okay, another question from the audience. Do you guys know how the different specifically about how Medicare reimbursed differently for female surgeons? Do you know how that's explained? Does Medicare know the surgeon's a woman, and how can we help correct that?
So this is a great study that Blair Marshall did looking at cardiothoracic surgeons. They do know the gender of the surgeon by NPI number. They do know the gender of the patient and the procedures. And this is a finding that's consistent in urology and ENT and other procedural specialties, including cardiology. So it's a consistent finding. Gender disparity, again, it's pervasive, every specialty. And I think, to Dr. Blackmon's point, it's we have evidence enough. I think we need to start moving forward and looking at how we negotiate, not only with Medicare, but also with our private insurers.
Great. One last question from the audience. There is a female surgeon that has two great male mentors. Should she look for a female mentor? What do you think, Dr. Wood?
I'm probably not the right person to ask that question to. I think congratulations on having two great male mentors. I think most of the women colleagues that I work with have strong male mentors and plus female mentors. So here I think it's less important what the gender is of your mentor than what they're providing for you and how much they are a mentor, sponsor, ally for you. And I think that men and women are can both be great mentors for women colleagues. So I guess I wouldn't, from my perspective, you don't specifically have to have a a woman as mentor if you have other great mentors, but I think it's great to have a diverse group of mentors that bring different lenses and different perspectives, and there a woman might complement the male mentors that you have and provide, in some circumstances, knowledge and information in a lens that is different than what your male mentors would provide.
I would say I've mostly been mentored by men throughout my entire career, and I'm not sure a woman could have done better. I've appreciated the fact that men have been willing to mentor me. I would say there are different levels of support that you get throughout your career. Mentors and sponsors, I think gender is not as important, but I do think support, it is very important to have other women in a support group or to bond with, or to who understand what you're going through. And we have several small groups. The Women in Thoracic Surgery has started a support group. Some of the issues that we struggle with are unique, and having help and guidance in those issues is very helpful. I've never had a male colleague really help me or support me when I was pregnant with twins and my feet were swelling like baked potatoes. They could be sympathetic, but they might not be able to provide the same level of colleague support that a woman could. But I think in general, mentorship and sponsorship is relatively gender neutral. Colleague support, it does help to have women. And then as we try to get more women to come into the field, I think it's very important that they see our presence and that we lift as we rise. That is so important.
Well, I think that's a great message to end on. Thank you so much for your wonderful presentations and this good discussion. And we'll turn it back over to John.
Thank you for attending this European Society of Thoracic Surgeons Women in General Thoracic Surgery and Women in Thoracic Surgery webinar series brought to you by CTSNet. Women in Cardiothoracic Surgery, united globally for progress. As a reminder, a recording of today's webinar will be available tomorrow, April 26th on ctsnet.org and CTSNet's YouTube channel. Have a wonderful rest of your day.